Namaste, this is Dr. Krishna Deepak and welcome to another episode of Steth Sip. And this is a unique podcast where a doctor, that is myself, will be talking to another doctor for the benefit of doctors. So this is by a doctor, to a doctor, for doctors. And today I am kind of nostalgic because life has come full circle. Because the person sitting opposite to me, I know him very well. He has been with me since my pre-med. And we both did long term together also. So without any further delay, I would like to welcome my very close friend and physician par excellence, that is Dr. Vamsee Krishna. Vamsee, I know you, okay, but for our audience, tell us more about yourself. Where are you from? Where did you do your MBBS, your PG, and a little bit about your professional, expertise.
Yeah. First of all, thank you, Deepak, for having me for today's show. So to begin with, I did my MBBS from Asthma Medical College. It comes under NTR University. So I'm basically from Hyderabad. So roots are from different parts of the combined state. So but I'm basically from Hyderabad. So what happened was in the B category, I had to move to Vijayawada side. So that comes under Andhra University. So as the state got divided, so when I had to do my PG, so what happened was I went to Karnataka.
Okay.
Because my passion was doing medicine, general medicine, and you know very well, whenever a general medicine professor walks into the hospital, like how we speak behind his back, general medicine professor, the knowledge what he has got, the kind of cases he treats, the variety of cases he treats, the number of cases or number of patients, he brings changes into their lives and all. So that was a big passion. So because not downgrading any other branches, but surgeons, they have their own this thing, and other things, non-medical things also, they have their own advantages. So but for me, being a physician was a passion since then. So then I had to do this thing. So but I was getting surgery branches here, but I was getting some medical branches in Karnataka, so I had to shift there.
Wonderful.
So then what happened? So as I completed my MD, so then came the time of super specialty. So our chapters, as you just told, we started maybe from the time we were wearing simple shorts and jeans. From there to now we are dressed up professional, and we are speaking now on the stage. So then what happened? That was the time when state got divided. So I had to apply for my super specialty entrance. So then as I applied, I became non-local to every part of the country. So because Karnataka I wanted to apply, they told you have studied here only 3 years, so yes, you can't be a local here. So I came to Telangana here applying. They told the qualifying exam is MD. We have done MD somewhere outside the state, so we can't. So because Andhra, when I approached Andhra people, they told you have done only MBBS here, but again your domicile is from Telangana, so we can't take you, so you're non-local to everyone. So maybe because I'm in the own country.
I think I bypassed this by doing DNB. DNB is safer bet in this kind of scenario.
Yeah. In a way it was far better. So but at least I had that confidence that I completed at least my master's in general medicine. So then what I thought, I was just wondering, so what people will be jumping around doing super specialties, after that doing some fellowship courses in abroad and all. So then what clicked me in my mind is there are two things which form the most important part of left side of our body, the pocket and the heart. So ultimately, anyone, let it be you, let it be me, or let it be anyone from any other profession, any work they do. So two things are important: pocket satisfaction, at the same time heart satisfaction. So I thought, okay, maybe after doing super specialty, maybe my pocket will be satisfied more than me being settled as a physician. But nothing that physician should be downlooked upon. But I thought, okay, professional satisfaction is also important. So I thought, why not to explore in the physician department only? Why not to bring some change to the physician department? So we can do wonders, and we need to spend some time. As you all know, we are in this system. Then after I gave 2-3 attempts for super specialty, so then I thought, okay, the best rank which I should get was only first rank. If I get above first rank also, I would be denied a seat. And so I thought, okay, I would settle with physician. And one more important point why I settled as a physician was, so because the number of cases I see, so wide variety of cases, which I can proudly say no other doctor can see. So I means like again, as I told you, not downgrading anyone else. It's individual's perspective.
Being a physician is a dying art nowadays.
Yeah.
Because I see ace cardiologists, ace oncologists, ace gastroenterologists, but when I was studying, we had ace physicians, and now it is becoming a dying art.
Dying art.
And it is thanks to doctors like you that we have to keep this an important aspect of medicine alive.
Exactly.
And if you ask me, I think we should follow something like the Americans do.
Yes.
They don't have MBBS. They directly become MD.
MD, yeah.
So we should see, this will create a kind of a bigger pool of physicians, trained physicians in our country.
Yeah.
That is something we can hope for.
Yeah, but surprising what happens is if you look at the system in West or in American, so like to meet a general physician, it might take 1 month of its time, and to get a procedure like endoscopy or something, or maybe to get a CT or MRI done, if it is a stable case, if it is an elective thing, we all know, no, what is the waiting time there? 1 month, 2 months sometimes, and doctors there maybe per day in an OP they might not see more than 10 cases also.
True.
But compared to our system here, you know, we already worked in some kind of government setups and private setups, some number of cases we see. In a sense, we are lucky actually to be in India. So because let that be a super specialist, broad specialist, or whoever it is, even at mid times, a call away, just a call away. So such lucky our people are. So but unfortunately, maybe the kind of respect or the kind of, earnings which we get are very less compared to what people get there in our counterparts get there in America or the Western world. So, but even then, as you told, it's a dying, dying art or science, whatever you name it. So, but I still feel physicians are the prime or the cornerstone of any hospital, or to that matter, any health system in our country.
I agree with you on this because, see, I worked in a multi-speciality hospital. We had all top specialists for respective specializations. But at the end of the day, when a primary diagnosis is finicky and they are not able to identify the exact thing, it was always the physician who was called in and asked, what do you think?
Yeah.
We are not able to understand what this is. So use your magic and tell us what it is.
If I can speak something sarcastic, maybe that's the reason topmost hospitals, or you may name it corporate hospitals, won't like physicians properly. So because they won't let the case go to super specialists also.
Yeah, true.
So, but I have that.
The professor I trained under at here for my DNB, whenever I used to see a hypertensive case, for example, I'm not being very specific for obvious reasons, and when I was a duty medical
officer,
not officer, registrar.
Okay.
I was doing my DNB.
Okay.
So in casualty, and I see a hypertensive case, hypertensive is medical case. They used to call me. I used to say, hypertension, accelerated hypertension. Let us admit under cardiologist. Next day morning, you said, why can't we treat hypertension cases? Why did you admit under cardiology? Yeah. What is the need for that? You don't know how to start NTG?
Yes, exactly.
So this is how it is. Wonderful, wonderful.
Yeah.
So how is your physician journey till date? Have you seen any case in the recent times which has baffled you, confused you, or for me it is always in the previous times, go back to see the books, but now internet is quite good, so we can have ready references. So is there any case that comes to your mind that actually recent times?
Almost every day. Almost every day. So that's the art of being a physician. That's the enjoyment I get being a physician. Yeah, because maybe cardiologist you will be seeing around the heart, nephrologist you will be seeing around the kidneys, but I would be looking after the ailments that are there in the entire body. So just to name recently, just last few days back also, like we had a case. He was a petty child, barely 30 years old, and like when he was delivered, so it was a forceps delivery. So he had some fixed abnormalities, fixed flexion deformities in the body and all. So he developed seizures and all, and he had hydrocephalus and all. What happened? He was put on VP shunt, and he had this kyphoscoliosis and all also. The problem with him was like, he was not able to move his legs.
Okay.
Off late since 6 months or 1 year or so.
Okay.
And with severe abdominal distension and collection in the flanks, back and all.
Okay.
Severe low backache. So he went around many people. He wasn't getting a solution at all.
Okay.
Like he went to neurosurgeon. He went to a cardiologist and like to see, because he was having certain breathlessness. So for the reason he went to a cardiologist. And like he was seen by neurophysician also.
Okay.
So like he was seen by surgeons also, like to see why the distension and all. Of course, everyone nowadays, like diagnoses are like a bit away. Diagnostic centers are just a click away from our place.
Yeah, true.
We are getting this home collections and all also, no? So he was worked up very clearly. Fortunately, unfortunately for him, what happened was like diagnosis was not made. So they were making a diagnosis of like collection here, collection there, some psoas abscess with destruction of spine and all. But etiology was not made. So unexpectedly, from one of my great friend, the case was referred to me. So I took it as
What is the
challenge.
duration of symptoms in this case?
Almost in 6 months.
6 months.
6 months. But he had been suffering many issues since he was a child. So because from the time of birth itself, like he had that forceps delivery, which was not so successful. So he had so many problems with him. So can you imagine? So finally, like I took up the case. The final diagnosis I made was tuberculosis.
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 Pot spine, huh?
Pot spine with the psoas abscess spreading all over. Spreading all over, causing destruction of the vertebra, cauda equina, and making him unable to walk. And after
So, see, let me tell you, for all upcoming doctors in India, if you are not able to diagnose, especially if you have PO, pyrexia of unknown origin, if you are not able to diagnose, you are not able to, you have done all the tests, and you know what we are left with? Only two. Either it's cancer or it's TB. That is the one thing that we have learned during our days in medical residency.
Yeah.
Nice. Psoas abscess.
Yeah.
Okay.
Psoas abscess, finally.
Pot spine.
Pot spine. Like it was an active TB. So unfortunately for him, it was rifampin resistant.
Oh.
So all that I could make out. So that gave me an immense satisfaction, because he came in like almost in paraplegia state. He went walking home.
Wonderful.
So we planned for spinal fixation later. Now I will hand over the case definitely to the neurosurgeon. So
obviously.
I made my diagnosis. Whatever good I can do, I have done for him.
Wonderful, wonderful.
Yeah.
So this is the importance of clinical history taking and
Exactly.
examination, and having at the back of your mind a kind of differential diagnosis,
Yes.
which will be missed by most super specialists. Wonderful, wonderful.
Sometimes, and one more case also, if I can
Yeah,
say.
yeah, please.
Yeah, so it was a pregnant lady. She was some 4 months amenorrhea, and she came with typical symptoms, only swelling of left arm.
Okay.
Nothing else. No no
Breast,
chest
nothing
pain,
like-
nothing, no soft tissue abnormalities, nothing, no neck pains or radiating pains or
Pitting,
anything.
non-pitting edema.
Nothing, only swelling.
Swelling.
Only swelling of the left arm, not in the forearm also,
Okay.
only in the arm area.
Okay.
And sometimes pain.
Okay.
It has some waxing and waning episodes also.
Oh.
So morning sometimes it comes, evening it goes off. With work and all, with increasing exertion, it disappears. Sometimes she says, sometimes it increases. So, vague picture she gave. And incidentally, she gave the history during her first pregnancy also.
All right.
So somehow they managed, it went unnoticed. So this time the pain was unbearable. She came to me. I took so much history and all. Instantly what I found was like she was operated for tetralogy of Fallot also
Okay.
when she was a child.
Uh-huh.
So then that gave me some spark again. I was thinking what to do, and I investigated. Finally, it was SLE with multiple connective tissue disorder overlap.
Okay. It was SLE.
SLE.
Okay.
SLE, weak SLE with RA factor being positive, anti-CCP being positive, ANA profile, it was suggestive of SLE a bit, and with the multiple connective tissue overlap.
Okay.
So finally,
And very odd presentation. Only no other joint or no other skin manifestations.
Nothing. So this is the kind of happiness or joy being a physician I get.
I think the
treat
patient will
patients.
come back again because I think her story is not done. Maybe, we are like, treasure hunters. We dig, we find something. But after that also, maybe we have to dig more.
We have to dig.
I think her story is still
But at least
incomplete.
the responsibility is on us.
Yes, true. Very nice. So, the main problem that I'm seeing nowadays is we are finding less physicians, and we are having a lot of students who are completing MBBS and who are writing their post-graduation entrance
exams, yeah.
and trying to get into a specialization. what should be the mindset of people who want to take general medicine, and what is the future that you see for general medicine who want to remain as a general physician? What kind of future do you see in
So like
the next decade?
as I told you, so like maybe we are equally knowledgeable, and we have equal knowledge like maybe some other fellow doctors of different streams. But thing here is like, if you want to be a satisfied doctor, take general medicine. Like if you want to earn more and if you want to see so much of revenues, so jump into surgical branches or the super specialty branches, because that has become order of the day in our country. The system is like that. And as we discussed in the beginning of the talk also, if you go to a hospital in the United States or in, for that matter, NHS system in the London or the Western world, so if you say chest pain, if you're having chest pain, they themselves will tell you meet physician first. So like in India now,
no, not even physician, family physician, GP.
Female general practice. GP is the one they call. So they ask them to meet. So and unless he gives clearance, like then they are supposed to meet a cardiologist. But here we have that much freedom. If you have a chest pain, you can directly dash into a cardiologist. OP, and you can go and meet him and take advice.
I think with lot of insurance, health insurance making inroads, and people finding a lot of what you call seeing that the medical costs have gone up, and everybody choosing insurances. I think slowly insurance companies will stop this habit of directly meeting specialists.
Already like
because at the end of the day, they are worried that their revenue will come down.
As I'm on board, I can't name so some companies. They have already started this.
They have already started.
They have already started this. I can't name. So because they are coming into this package systems. See, for example, if someone comes and gets admitted with us with acute gastroenteritis, so they are going to give you only this much amount.
Yeah.
So depending on your hospital. So if you say, because if the patient has some ECG abnormalities, it's a routine practice for us to do 2D echo, or if the pain is very acute, some troponin kind of test, or call a cardiologist. So the patient gets admitted for acute gastroenteritis, but incidentally you found something else, but you would be paid only for the gastroenteritis package.
Okay.
The system has already begun in our country also.
There are pros and cons,
Yeah.
but I think that is maybe future generation and policymakers should be more inclined towards it.
So when the situation is like that, so it will be quite natural for the budding doctors also to select, like they might feel that the quality of life is when we do super specialty. So but still my suggestion is, if you want to be a satisfied doctor and if you want to see wide variety of cases, and if you don't want to limit yourself to one particular system in the body, you can be with general medicine.
Wonderfully.
We can
very
very well people
said.
can do wonders.
Very well said, and I agree wholeheartedly.
Yeah.
Now, our country is facing certain challenges, and today when I wanted to meet you, I was actually looking up some statistics, because National Family Health Survey 6 has come. And my primary interest is, I have seen as per National Family Health Survey 5, almost 60% of women in reproductive health age group are iron deficiency anemia is there. So I was eagerly looking at the latest stats, and I came to know that the government has removed the anemia aspect from National Family Health Survey 6. So you know that anemia is a very serious issue in our country, and I think in your practice you might be seeing anemia cases left, right and center.
Yeah.
So what is your primary policy? What are your cutoffs? How do you approach a case of iron deficiency anemia?
Here two things, like when we do first, if we talk about the symptoms of anemia, it can be simple lethargy. So it can be generalized weakness, or it can be sometimes lack of concentration, or it can be sometimes hair fall also. To severe things like shortness of breath, and at rest, shortness of breath at rest, or while you walk a few steps also.
Absolutely.
So but anemia can present with this combination of symptoms or a single symptom alone. So the moment you do, the common thing what we do, the investigation what we do is the complete blood count or the complete blood picture. What happens in our country is, as soon as you see the complete blood picture, and it's a habit for every one of us, maybe for the doctors or the patients also, to see the normal range, normal specified range. So as we all know, the normal specified range hemoglobin levels for male individuals in India, it's somewhere around 14 to 16, and for females it is 12 to 14, 11 to 14, 15. So 1 gram here and there. So the moment if someone comes, say for example with hemoglobin of 10, so it has become a practice to start off with iron supplements.
Okay.
Start off with iron supplements. Like the people are unable to identify the cause. So hemoglobin is 10, start off with the iron tablets. So that should not be the practice actually. So we need to take history, as we discussed in the one case which we were discussing. We need to take proper history, and after that we need to evaluate. The simple that complete blood picture will give us so many details, as we know. So the peripheral smear will teach us many things, and depending on that we should plan further investigations, and sometimes maybe like to the tune of bone marrow aspirations like CT scans, enterographies, endoscopies, colonoscopies, and HB electrophoresis kind of tests, and mineral analysis, vitamin analysis, and to see what kind of anemia exactly it is. And after that, if you can plan the treatment, it would be much better.
Wonderful.
So it would be much better.
Because what you said is right, absolutely right. What I tell to my juniors is that you correct the anemia is like the overhead tank of your house is empty. And you're trying to pump water into your overhead tank, but somebody downstairs has opened the tap.
Open the tap.
First find out where is the tap leaking.
Exactly.
First shut the tank, then tap, and then put the water in.
Yeah.
Wonderful. Anemia of chronic diseases is basically because, to put it simply, is because of high inflammation leading to IL-6, hepcidin.
Accepted.
And it kind of stops the oral iron absorption, especially when you have chronic inflammatory conditions, maybe your CKD patients or your heart failure patients or even rheumatoid arthritis, all these patients, they do present with anemia of chronic diseases, where oral therapy becomes a challenge.
Exactly.
So how do you approach to these patients, and how do you correct iron deficiency in these
because
patients?
as we were just discussing, when you are treating an anemia case, so like cause may be anything. I mean, the etiology can be anything. So 3 steps in the treatment. Severely anemic, they might require blood transfusion, and moderately anemic, they might require oral supplementations with parenteral IV therapy, and just mildly anemic, maybe oral supplements would suffice if the diagnosis is iron deficiency or if the diagnosis is B12 or folic acid deficiency. But the kind of cases which we see are like, of course, definitely we see the severely anemic cases and mildly anemic cases. The moderately anemic cases are the ones which are more in number. So like the problem here is by the time they reach us, so they might be going into the severe anemic stage.
True.
So how we would be knowing whether they are going to severe anemia or not? So not just by hemoglobin levels. So we need to estimate ferritin, TIBC, and serum iron levels. We need to do all that.
Transferrin saturation.
Transferrin saturation and all that we need to do. And if the patient is having deficiencies in all these things also, TIBC would be of course more than the normal in iron deficiencies. And if the iron stores are very low, if the ferritin is very low, then along with the oral supplementations, important is like we have to switch over to the parenteral iron therapy. So that's most important. Like of course, people are becoming aware, doctors are becoming aware, patients are becoming aware. So they themselves are asking the doctors also like how to go about and all. And like no one is fearing away from, before if you say injection means like our population especially would shy off. But now they are not so, they themselves are asking. But important here is like oral supplementations, like thousands of brands are available in India.
Absolutely. So what formulation, I mean, I'm sorry to interject to you. There is ferrous sulfate, the oldest, to ferrous ascorbate, which is preferred by the gynecologist, to we have this microsomal iron tablets, which are absorbed from the M cells of intestine. So what do you choose? Liposomal preparations are your choice.
Because recovery is fast.
Okay.
And I mean like here again, 2 different things. Not just improving hemoglobin levels, we need to improve the ferritin and iron levels also. And if you improve just hemoglobin levels and if you leave, the patient still has a problem, and sometime later again he will knock our door. So sir, I'm having again this kind of thing. So again here, iron preparations, they are very important. So if needed, so if we put it in a nutshell, and if it's a moderately anemic case, we need to follow these 2 steps. Giving them supplements with iron tablets or iron preparations along with the dietary modifications, and also parenteral IV therapy is also very, very important.
Okay. So the reason why I'm actually asking him about iron deficiency and everything, I recently referred 2 cases to him because I don't have the setup to give parenteral IV, and sir has a setup. So Your argument is absolutely right, but my hesitation in this is, especially working with a lot of pharmaceutical agents and studying them in greater detail, I find it that even with moderate anemia, correct me if I'm wrong, and especially with anemia of chronic diseases, don't you think that by giving oral iron, and we know that oral iron absorption will be severely curtailed because of the inflammation, we need to shift over to parenteral iron therapy?
Yes, parenteral iron is very important, which was underlooked all these years. So now, as you told, pharma companies are also coming with good preparations. So earlier, dextran-based and non-dextran-based supplements were available, iron injections. So now, luckily, we have some preparations called ferric carboxymaltose and all. And so those are the ones, like with sometimes 2 shots or 3 shots would suffice. So earlier we had preparations like iron sucrose and all. So they had the severe risk of anaphylaxis. I mean, it's like I can't name here, but I had one of my professors, better half, who passed away on the table.
Oh my God.
With the severe anaphylaxis shock after taking iron sucrose.
Oh, okay.
So that incidences are coming down with the latest iron preparations, and obviously, like we would be easy when we are traveling or somewhere. If it is a small briefcase, it would be easy for us to carry. So like if you iron sucrose and all, if you ask the patient to come for 10 times, maybe they would not. So but with the latest FCM kind of preparation.
So iron sucrose maximum dose, I think 100 to 200 per sitting.
Yeah.
And you can't go more than 3 sittings in a week.
You can't go.
And that will come up to 300 to 600 maximum.
Yes.
But your preparations, 1000 and plus you can go.
Yes.
So that is definitely an advantage. But iron sucrose is cheaper and your parental preparations are a little expensive. But
expenses, if you ask me, on the longer term, on the longer setting, it will be almost the same.
Yeah, you're traveling in a
you have to be in a
bed
hospital.
charges.
Bed charges. And every time you need to put a
cannula
and change it.
Yeah, true.
Observation charges.
There was a study actually which was done in Delhi comparing iron sucrose with ferric carboxymaltose. And they said that ferric carboxymaltose was cheaper because all these additional costs are actually eating into iron sucrose. And iron sucrose molecule also, I have seen the representation of it. The sucrose moiety is very loosely attached to the iron core.
Yes.
And because of that, the iron sometimes is in free form, and as we all know, iron is highly reactive. Wonderfully said. Next question is, we have newer molecules like ferric carboxymaltose, fermoxetol, iron derissomaltose. So can you just tell me, among the newer molecules, what do you think is better?
So like the newer ones, definitely they come with newer advantages. But right now, without any fear, if you want to give, and like leaving about anaphylaxis, like the shock kind of things, allergic reactions or anything, ferric carboxymaltose is doing good.
Okay.
Doing good at the moment. So yeah, the other molecules which you said are also extremely good. But maybe some more results are awaited.
Yeah, true. Evidence for FCM, ferric carboxymaltose, is quite high. And I have seen that FCM is approved for pediatric age group, above 1 year age group. It is the only pregnancy, obviously. Then even heart failure. There is this confirmed heart failure trial is there with ferric carboxymaltose. So true.
CKD also.
CKD goes without saying.
Will be given along with that. This also.
Yes. We are not nephrologists, but I think we should tell nephrologists. See, I came upon a very interesting thing, that ferric carboxymaltose is available at 500 and 1000 mg.
Yes.
750 mg also outside India, the innovators have that. But here in India, we are a Jugadu country. We are having 200 mg also. And I was surprised, and they said that this is for dialysis. And then latest KDIGO guidelines say that don't do that. Don't keep small amounts of FCM or iron sucrose in one sitting of dialysis. Correct entirely in one session, because it improves the CV risk.
CV risk.
So wonderful. So see, parenteral IV therapy is what I have studied, is that you have to calculate the iron dose as per Ganzoni formula.
Yes.
So, but I don't think physicians or gynecologists or any specialist who's treating IDA has the time to calculate. So what is your jugaad in, how do you calculate the dose?
Yeah, I'll tell you. So as per the formula, we need to go. And if you're not remembering the formula, so we are very poor at mathematics. So
Formulas, yes. Body weight into 2.3 into 15 minus present hemoglobin.
Yeah.
Weight less than 50
Yeah.
plus 500. Weight more than 50 plus 1000 for ferritin.
You told me what all I have to tell. So put that formula, and the most as per our requirements, it will be somewhere around 500 to 1500 mg requirement. So depending on that, you can calculate the dose either consecutive days or weekly once you can give. So 500 to 1500 mg is the average dose which our person would be requiring, our regular patients would be requiring.
True.
Sometimes some patients might require more, especially if it is a malabsorption case or something. But ideally, so as you rightly told, no one has such time to calculate.
Yes,
so but after you calculate also, say for example, if the requirement comes to around some odd number, 750, 800, 900. So still we would round it off to the next number, right? So there comes the idea of giving 500 mg or 1000 mg or 1500 mg.
Yes, true. Wonderful. So I am interested in what is your jugaad. For example, patient is having HB of 9. So do you calculate as per Ganzoni or do you have some your own?
I go as per the formula. I go as per the formula, and depending on the whatever is the result that comes in the formula, I would like.
Wonderful, wonderful. So what are the typical adverse events that you usually see with the newer formulations like ferric carboxymaltose? See, let me, with your experience, try to understand this. What we have seen is, it's not like an antibiotic, we can't give test dose.
Yes.
But I have seen physicians, and including myself, I am also guilty of this. We used to run the 5 ml or 2 ml to 5 ml, we'll run. We'll flush and see if there is any reaction. If there is no reaction, we used to give the entire dose. But I have read some studies which say that even if there is a reaction, it is usually very small, and you can give it because our understanding is if we see a reaction, the patient is absolutely allergic to it, don't go for that.
Yeah. So leaving about what our consent says, the patient wouldn't accept it.
Yes.
So the moment he says he develops some kind of itching kind of thing, redness over the body and all, he immediately suggests us to stop it. So, but if you can counsel the patient, if the patient is listening to you, if she is a comfortable patient, then we can still continue. But as you told, maybe if the companies can come up with this idea, how to rule it out, how to rule out the hypersensitivity even before we start it, it would be better. So some medicines, especially vaccines and all, they come with certain preparations. If someone is allergic to that, we don't give that preparation.
Understood.
And some medicines, they come with protection of eggshell and all. So if someone is allergic to egg and all, we don't give those formulas. And some patients are allergic to the polymers or the dyes which we use to bring the color and all. And if someone is allergic to that, we don't use those medicines. So but now it's crude thing, but the thing available is running some 5 ml or few drops, and if the patient is comfortable, flush NS and continue the rest of the infusion. So that's the only thing available now.
Wonderful. So I read a very interesting recommendations from Indian Academy of Pediatric Hemato-Oncology chapter. They said that FCM does not require pre-medication. But in certain populations, you can give. In certain populations, like for example, children who are having bronchial asthma
kind of allergy,
juvenile arthritis or these kind of thing, you can give a pre-medication of methylprednisolone. They gave it as a recommendation. Do you think this can apply to even adults? Because many of the doctors are worried about giving parenteral iron.
Yes, definitely we can do. See, because again, here the thing comes is if the patient is already having allergic tendency more, so we don't know the serum IgE levels or the absolute eosinophil counts even before we start. Maybe AEC levels, maybe we can, with the CBP picture we can calculate, but we don't know the chronic allergy status, and see if we don't know if the patient is having asthma kind of things also after we see, even if we fail to take a history. But giving pre-medication is definitely recommendable. So maybe if it's yet to hit the recommendations book, but still maybe we can, no problem, like we do before the blood transfusion. we give like antihistamine, sometimes a diuretic.
Diuretic, yes.
Yeah, corticosteroids.
We will
Maybe if not all these things, we can give a short dose of corticosteroids.
So steroids are not bad.
Not bad.
Steroids are very important.
Definitely.
You know
not
what
bad.
happens in my practices? I write Devzelocort. And as soon as they go out, they come back inside and say,
Steroid. It's a steroid.
"Sir, this is steroid."
Steroid. You have written
So
steroid.
I look at them and say, "No, it's not steroid. It's a corticoid.
Cort-
It's a different thing. Please use it."
Yeah.
There is, for his condition or her condition, that is the right medication.
Yes.
And the amount of bad, word steroid has become, even in real usage, when there is recommendation is there, it becomes tough for us.
Yeah, because there's a problem we see with unregistered medical practitioners. Their idea of practice is to give one painkiller, one steroid injection
That's
together. So people might not like this what I'm saying now, but that's a thing which we observe, the bitter truth. So maybe that's one of the reason that apprehension is coming to our public's mind. So steroid means it's something draconian kind of thing, which we should not use. But because after spending this many years of study and having this many years of clinic practice, don't we know for whom to write a steroid and for whom not to write? Yeah.
And I don't think general public knows what our tenets, what our guidelines are. The first thing is do no harm. It is not to treat.
Yeah.
The first tenet is do no harm to the patient.
Yes.
So if you don't know, please go back. That is what is taught to us first.
Otherwise, you have the option of referring. So you can refer to your friend or
Definitely.
some other specialist. So that's it. So such a beautiful place if we are in.
Well put. So what is the lowest cutoff without any kind of cardiac decompensation, HB level, that you prefer to give parenteral iron therapy?
Parenteral iron, if the ferritin falls below 20, if the ferritin falls below 20, I think we should.
No, what I'm saying is HB.
HB.
People have this, as soon as they see 6 HB, they say this is a blood transfusion case.
No. I understood what you are asking. So below 6, better at least 1 or 2 units of blood transfusion to start the things with, so that we can avoid the patient landing in complications. And sometimes they are going to severe heart failure and sudden deaths also. So but if someone comes with hemoglobin of 9, 10, but as I told again, we need to assess for the ferritin levels and iron levels and other things and start off parenteral IV therapy immediately. So if you think I'll put it this way, and if you think our blood as a delivery system, in that the truck is the red blood cell, and who forms the base for the truck or the body of the truck is formed by the hemoglobin. So hemoglobin is essential to carry oxygen from one place to another. It means oxygen is fuel to every cell of the body. So what if again hemoglobin is made of heme and the globin part, and if you are deficient in the heme part, the truck is punctured, there is no proper delivery system, and the patient lands into trouble. So for truck to be in proper condition, maybe to put it in a colloquial way, and if it needs to be serviced properly, so heme should be proper.
Wonderful.
Heme should be proper. And for the heme to be proper, and if you want instant result or immediate result for the heme to get stronger, parenteral IV therapy is the only option. So tablets, they will increase the hemoglobin levels in the long run. So maybe they will also increase heme levels, but in the long run, it might take 2 months, 3 months, so sometimes up to 6 months also.
Compliance is a big issue.
And
even gastrointestinal side effects.
Are there. So people claim, but especially pharma companies claim with newer oral preparations, the gastric upset kind of things are coming down. But still, parenteral IV therapy, 1 or 2 shots or maximum 3 shots, you're comfortable.
Wonderful. I have recently seen one of recommendations of a gynec recommendations. Certain hemolytic conditions where ferritin is extremely low, even there they are advising that you can increase the ferritin levels with FCM. Is it true?
Yes, exactly. So because there is, in those conditions, especially hemoglobinopathies, so beta thalassemia trait or beta thalassemia proper or sickle cell anemias, there is no point pumping with oral supplementation. So how much ever you give, the hemoglobin will be at that certain level only, and the absorption won't be there, and there will be too much lysis because in hemolysis. So when something is lysing immediately as soon as you take, there is no point giving it. and there is no fun actually giving it much. So then there comes the role of parental IV preparations. You give much it is, the better. And
But
if
you should monitor.
Monitor.
You should not let ferritin go above a certain range.
Because storage of ferritin is also troublesome to the body. So it should be in the compliant levels only again.
Wonderful, excellent. Let us switch gears a little bit and let us come to the burning topic of today, weight loss drugs. Where do you stand on that?
So weight loss drugs, if you don't mind me cracking a joke, so we two are the person.
Yeah, more than you.
So that's the thing. So weight loss drugs are good actually. The invention that has gone behind and the amount of research that has been added and put, the amount of money that has been poured in, and again we are lucky enough to have that molecules at a cheaper price in our country. So but they are very good. So but even before the problem here is like people are self-administering.
Yeah, true.
So without proper diagnosis and without proper instructions, without proper idea actually. So they themselves are getting it available from the market and from the medical shops, and they themselves are administering also. So and there was one thing in news of late, and I think if I'm not from the Bombay area, Mounjaro bride. She was named Mounjaro bride.
Okay.
So, because she took before her marriage, she took Mounjaro injections, and after that she lost her weight. So that's good actually. Losing weight is always good, as we all know. Losing even 5 kilos of our existing body weight will bring down burden of so many complications. But here thing is like if there is no proper direction and if there is proper supervision, it will be like again a disaster.
So your BMI cutoff is what for?
24, 25.
24 is 24.9 is normal only.
Normal. So above 30.
Above 30.
25 to 30, maybe we can still manage with diet and exercise kind of things, lifestyle things. But above 30, and if you are eyeing for a weight loss thing, definitely these injections are super.
Absolutely. So now we have two molecules which are in market right now. We have semaglutide and we have tirzepatide. What is your choice and why? And is it like not like that? For certain conditions, I prefer semaglutide, certain conditions, tirzepatide.
Yeah.
How do you go about it?
See, if the patient is having already diabetes also, so and if the patient is not having any diabetes or other kind of things, maybe semaglutide would be better.
Okay.
And if the patient is not having diabetes but still they're eyeing for weight loss, maybe tirzepatide would be better. But efficiency wise, because I'm not supporting any company or anything, so but tirzepatide scored more.
Yeah, it has dual action.
Dual action, no, so it scored more. But safety wise, results wise or evidence wise, it's better with semaglutide.
Semaglutide also has been there in the market for a longer time. So we know the adverse events.
Yes.
What is your take about, see, one of the box warnings is people with familial history of carcinoma thyroid.
Yeah.
So how applicable is it for Indian context? And because we do get carcinoma thyroid, but is it that prevalent, and do we have to take extra precautions in that kind of thing?
At least I've seen this also. I've seen few of my friends or colleagues like doing complete body analysis and after that switching over to semaglutide or something. And they're just writing it off. If they're just taking oral history, and if there, as you rightly told, if there is no family history or positive or negative family history, maybe they're using it off for semaglutide or tirzepatide. But there are some things called pharmacogenomics, and in abroad maybe it's very easy. So for them to take a drop of blood and to analysis for like which kind of cancers markers and we are prone to, and at least if someone can afford that, because those are costlier things in India and not so affordable for general public. And if you can afford those kind of things, not just for screening of thyroid cancers or some other cancers, or not just for weight loss, that will be helpful for you to understand your body better. So what kind of problems you might be prone in the future, understand that, and in these investigations, if there is no risk of medullary carcinoma of thyroid or some pancreatitis or something, maybe you can go ahead.
Wonderful.
That's you're on the safer side. Even if you're not, if you lose money also, if it's not an issue for you, maybe you can.
One thing that people do miss, and I think through you I would like to convey that this is not just you use it for 3 months or 6 months. You need to have a maintenance.
Lifelong.
Yes.
Lifelong.
You elaborate on that.
Yes. Lifelong. See, the moments what happens is like, for easy understanding, it will satisfy your satiety center fast. So you will tend to eat very less.
True.
So once you stop taking the drug or the injection, your satiety won't get satisfied. You tend to eat more. And all these years of hard work, all these years of hard work you have put in, and the weight loss you have seen, the results you have seen, will go reverse again. So that's the reason. So not just start and stop, start and maintain.
And one more important thing that we need to warn patients who are on this is they have to have a meal plan. Otherwise, they'll have something like the semaglutide phase because they lose protein.
Yes.
They lose muscle mass.
Yes. The sarcopenia is very much an issue with these drugs. So static exercises and all should be followed along with strengthening exercises and having more of protein diet and all. Otherwise, that semaglutide phases and all are the new things which our people will be learning.
Yes, they will look drastically different. They will look like they are having some form of I don't know, very debilitating STD or something like that.
You can put it like some zombie kind of.
They do look like that.
Yes. That's there.
So that is one thing. So coming to a very sombering question. We both are 40 plus. Okay. So what should a 40 plus, because in one of the podcasts, one of the doctors I was discussing, 50 is the new 40, 40 is the new 30.
Exactly.
So we are doing more than what our parents are doing, have done, or our grandfathers have done.
Yes.
Our lives are drastically different.
Full of pressure, tensions and all.
So what do you think above 40 or above 30, what are the things that normal population, people, Indian context should be doing?
Like it might be easy giving lectures, sitting before the mic and do a podcast and all. But as I told you at the beginning of my talk today, satisfaction. If you're satisfied, you're content with whatever you have, maybe the chances of you falling into prey of these deadly diseases won't be there. So apart from that, that's a different thing which is completely subjective. Nothing is in our hands sometimes. But from a physician point of view, if you want me to suggest something, the most popular annual checkups, the buzz which is there, and with a quick click of some app on your mobile, people are coming to your house, taking the blood, giving you results by the same day evening. But the problem here is like we should know what kind of tests to be done. So apart from the master health checkups, what people do, there are certain other tests which we need to see, because earlier maybe our parents and grandparents had the issues with infectious diseases, but now the era has changed. Now we are fighting with more of metabolic conditions than the infectious conditions. So because as you could see the surveys and all also, the metabolic diseases are hitting more than the infectious diseases nowadays. So to curtail these metabolic diseases from hitting our body, what we can do is like be more vigilant. So just understand your body better, not with the regular checkups alone. So maybe certain other tests like homocysteine, fasting insulin, apolipoproteins, and certain kind of other stuffs. And if someone is so much interested, and if someone is having family history of cancer also, they can do testing with the cancer markers and all, and they can be more fit. So that we can increase the longevity.
Wonderful. So, Vamsee, Dr. Vamsee.
Vamsee always to you, maybe for the general public.
So, thank you very much for coming and sharing your insights today. And it was less of a scientific section, more like two old friends sitting together and talking things.
I hope this will enlighten many people. Because regarding the scientific information with one click you can get it. So but this kind of general discussion from a doctor or to a doctor, it will be enlightening to more. And then let me thank you also for having me out.
My pleasure, thank you, and I hope that you face more challenges in getting complicated cases which nobody, the thrill of diagnosing when everybody misses the small thing is a high that no drug can give you.
Definitely, I would be waiting for that.
Yes.
So because that has become a daily routine for us.
So wish you all the best.
Thank
and hope you make save more lives.
Thank you, Deepak. Thank you for that. And let me thank your entire team also for organizing today's show. Thank you.
Thank you.